Hello, my name is Jennifer Combs. I am a registered nurse currently working at Walla Walla Community Hospice. I am here today to share with you about the use of radiation therapy at the end of life with palliative intent in patients with metastatic cancer. This topic struck my interest due to noticing how few patients receive radiation therapy while on our services. This brought me to my developed PICO question, which reads, in adults diagnosed with advanced metastases, is palliative radiation more effective in improving symptom management within the last 6 months of life compared to when palliative radiation is not received and only non-pharmacological and pharmacological interventions are used? With this topic in mind, I found 3 research articles with similar objectives. When looking at the components of the research process, all 3 were quantitative research articles. 2 articles were retrospective, single institution review studies, and 1 multi-institutional prospective cohort study. Each purpose for the article was similar, in that they focused on determining effectiveness of palliative radiation on patients with advanced cancer at the end of life. 2 studies examined terminally ill patients determined to have end-stage cancer, but one of those studies did exclude patients potentially receiving palliative radiation therapy to their primary tumor. The third study focused on patients being treated only to the brain and bone with palliative intent at the end of life. Sample size ranged from 145 to 518 participants. The research began by collecting data regarding demographic, socio-demographic, and baseline health status characteristics. Medical and treatment-related information was collected retrospectively from electronic medical records. General prognostic models were used within each study to determine the patient's performance status. Each study used a different prognostic tool to measure performance status prior to receiving radiation. This included the Karnofsky performance status, Eastern Cooperative Oncology Group performance status, and the Teach and Chow model with a BMI index. Within each study, patients were treated with different fractions of radiation. Each study then examined the impact of performance measures on palliative radiation therapy treatment, tolerance, and fractionation schedule. When looking at the overall quality and validity of these research studies, the limitations are as follows. There are multiple barriers that impede on the participation of research studies regarding patients at the end of life, which is why research is limited regarding this topic. In these particular studies, portions of the sample population were unable to complete the radiation treatment. Some of these reasons included decreased performance status, progression in their disease process, inconvenience of the radiation therapy, and death. Prognostic tool measurements can have subjective tendencies, and physicians can often be overly optimistic, in turn leading to inaccurate fractionation schedules, which may have contributed to patients' early discontinuation of radiation therapy. Within each study, patients were treated with different fractions of radiation. One study alone expressed using 1 to 13 different fractionations. The differing regimen of radiotherapy could be influencing the differences we see within patient outcomes, and perhaps a more controlled regimen is needed. The generalizability of the study, focusing on 2 of the studies, couldn't be as generalized due to how limited of a population they looked at. Finally, the studies did not include information regarding pharmacological interventions utilized outside of the palliative radiation. However, it was mentioned that it likely did play a part in improving quality of life through symptom management. When looking at the significance of the evidence, a common finding throughout each is the correlation between performance status and the effect radiation therapy had on their quality of life. Despite the prognostic survival tool used, Each article showed that the use of radiation therapy at the end of life should be targeted for those with a higher performance status. Those with low performance status, it is necessary for the healthcare provider to account for the palliative intent adversely affecting the patient. One research article showed that 100% of the patients receiving radiation therapy with a high performance score of 1 had high quality at the end of life, whereas those who did not receive radiation therapy with a high performance score of 1, only 50.9% had high end of life quality. Therefore, 49.1% with a high performance score of 1 that did not receive radiation therapy had a low quality of life. Results further supported that those with poor performance scores benefited less from radiation therapy. 14.3% of patients with a low performance score of 3 that were treated with radiation therapy had high quality of life, whereas 54.9% of patients with a lower performance score of 3 that were not treated with radiation therapy had high quality of life. High comorbidity and both fair and poor functional status were also associated with more frequently missed radiation therapy treatment days. One study alone showed that 42% of the patients did not complete their planned therapy course. When performance statuses are not accounted for accurately, a large portion of the patient's remaining life may be spent receiving treatment with little to no clinical benefit. Therefore, change is needed in regards to having earlier, open conversations with patients regarding treatment at the end of life. It is vital that healthcare providers determine their patients' goals and preferences and focus on individualized care. A practice model is needed with a focused intent on facilitating the delivery of palliative radiation for the patients who are choosing symptom management rather than curative. Additionally, due to the multiple barriers impeding the use of radiation therapy while receiving hospice care, insurance companies should explore and pilot programs that allow patients the option to continue with direct cancer interventions while receiving supportive hospice care. Additionally, due to clinicians' poor accuracy at predicting prognosis and survival of patients with advanced malignancies, a universal survival prediction tool is needed. This could limit physicians' ability to overestimate patients' life expectancy, in turn leading to providing better guidance towards end-of-life interventions, such as determining accurate, non-biased fractionation schedules. In regards to improved quality of care, since radiotherapy can only address focal disease, these treatments should be supplemental to holistic palliative care. It is a cost-effective intervention that can reduce end-of-life hospitalizations. Radiotherapy can alleviate a wide variety of symptoms such as pain, managing obstructive symptoms, relieving neurological deficits, decreasing the size of focal tumors, and ceasing bleeding. By better controlling end-of-life symptoms, one's quality of life can be improved. However, radiotherapy does not provide an immediate effect. The time from completing radiation therapy to symptom relief is measured in weeks to months. Individuals receiving palliative radiotherapy within their last weeks or months of life may see minimal to no clinical benefit. Careful consideration is needed, as the potential benefits of treatment may be outweighed by both expected side effects and treatment burden. To begin piloting the use of palliative radiation within the hospice organization I work at, I would begin with presenting information to the executive director, nursing director, medical director, and board members. Once gaining approval, I would begin the pilot program to focus on individuals with metastatic cancer to bone. Radiation therapy would be utilized to focus on better pain management in addition to pharmacological and non-pharmacological interventions. From the time of initial referral, the oncologist referring would differentiate patients with bone metastases who they feel would benefit from radiation therapy based on determining on determined palliative performance score and comorbidities. Those with high palliative performance scores would begin an individualized treatment plan of palliative radiation. Quality of life would be assessed through measures including clinical symptoms such as pain, with the use of a verbal pain scale of 1 to 10. Functional disability would be looked at through the utilization of the CATS activities of daily living, and we would also measure psychological well-being and life satisfaction. These assessments would take place weekly by the registered nurse until death. Those excluded from utilizing radiation therapy at time of referral with metastatic cancer to bone due to low performance score or due to patient preferences would have quality of life assessed until death as well. Through doing so, it would allow us the opportunity to see firsthand the effects palliative radiation can have on quality of life. The reevaluating process would include looking at the population that was treated with palliative intent to bone metastases versus those that were not, and reflecting on the quality of life based on recorded assessment findings. We would compare statistically the amount of patients who completed their individualized treatment plans. We would look at average length of life after completion of the treatment plan, and we would determine if quality of life increased or decreased after the use of palliative radiation. Additionally, we would reflect on whether palliative performance scores accurately reflected patients that benefited from palliative radiation based on length of stay after completed radiation treatment. If positive correlations are determined through the pilot program, then we can continue to reevaluate and broaden the population being treated to more than just those with bone metastases, overall focusing on each patient's individualized plan of care and providing better quality end-of-life care. This concludes my presentation. Thank you for your time.